You got so quiet. It's great. We were just waiting on a few speakers, so I thank you for your patience. Well, good afternoon, everyone, and good evening to our team over in Abuja, Nigeria as well. I am Leslie Mancuso, the President and CEO of Jhpiego, and I am here to welcome you on behalf of Jhpiego and on behalf of our partner, Last Mile Health. No doubt we are so pleased to have so many people here joining us for what we promise will be an engaging and thought-provoking conversation on providing primary health care while making the world safer against pandemics. Preparing for and responding to the next outbreak impacts all of us. Thank you. I just get a note. I'd like to welcome the Minister of Health of Lesotho, who is here. Thank you so much for being here, Minister. We always love when people come as a surprise, and that's wonderful, so thank you. Preparing for and responding to the next outbreak impacts all of us. As we know, pandemics spare no one. Large countries, small countries, prosperous, resource challenge, nations on the east, nations on the west. And health workers are among the very first affected. Women and men, nurses, community health officers, community health workers, who are all on the front lines in their health systems. They are the first to see symptoms, recognize the severity of the outbreak, and call us all to action. They examine and certainly treat the sick and bravely care for the dying, even when it risks their own lives. They are critical to the global response, and we simply could not have this discussion without them. We decided that despite visa backlogs and travel restrictions, that we would ensure their voices are heard. So we are bringing UNGA to Abuja, Nigeria. We are hosting this as a dual event with an impressive panel of primary healthcare workers in Abuja, Nigeria, which I will speak about a little bit from now, and as well an impressive group of global health experts here in New York. Our panel of primary healthcare workers have experienced firsthand the movement of people, the fluidity of borders, and the ability of diseases to grow and evolve. Infectious diseases don't discriminate based on education, affluence, or resources. And yet, a robust primary healthcare system with investments in health workers, a ready supply of medicine, strong ties to the community, and a network of information sharing can significantly impact a country's response to disease outbreaks. The experience of COVID-19 revealed just how fundamental strong primary healthcare systems are to achieving universal health coverage and defending against emerging infectious diseases. Rare is the country that didn't experience overwhelming stress on health providers, changes in service delivery, supply shortages, and yes, public skepticism over COVID-19 vaccines. And while each country experienced the pandemic uniquely, the global health community recognized the need to learn from this experience. That's why I'm heartened today by the choice of the United Nations to hold 3 high-level meetings this year on pandemics, on universal health coverage, and tuberculosis. These meetings present an opportunity for governments to recommit to putting health at the top of the agendas and to accelerate our progress towards the 2030 SDGs. In holding these meetings consecutively, the United Nations leaders have recognized the undeniable connection between universal health coverage, pandemic preparedness and response, and increasingly drug-resistant and deadly disease, TB. Jhpiego believes sincerely, as do our partners, Last Mile Health here today, that primary healthcare workers have the skills, the knowledge, the experience, and the dedication to provide essential services, engage the community, and identify and respond to health emergencies. Now, today I am thrilled, can you tell, that you will hear directly from an incredible group of health providers. Nurses, let me add, I'm a nurse, so obviously this is very special for me. Nurses from Nigeria, Burkina Faso, and India, and a community health worker, also from Nigeria, gathered right now in Abuja with their own crowd that's watching. Their lived experience of COVID-19 provides a sobering account of the quality of primary healthcare systems in communities and the challenges faced by responding to emerging infectious disease and the gaps in care. The other part of the panel represents our most distinguished global partners from the public and the private sector. They will add their insights and the reflections on the progress we've made to date, as well as the opportunities to support health workers, strengthen health systems, and as well achieve healthy, resilient communities. Now, to start us off, I want to introduce Dr. Rashid Tajuddin, the head of the Division of Public Health Institutes and Research of Africa CDC. A public health practitioner for more than 20 years, he has coordinated the strengthening of public health institutes across 55 African Union member states. Welcome, Dr. Tajuddin.
Good afternoon, colleagues, ladies and gentlemen. Good afternoon, my brothers and sisters in Abuja, back home. I bring you greetings from the Director General of Africa CDC, who would have actually loved to be part of this discussion. But as you all know, there's so many engagement going on as far as this UN General Assembly is concerned. So when I received the directive from my boss that she should come and stand in for him here, I look at the topic, I said, was it that because I'm from Nigeria, that's why I was chosen to come and give this keynote address. So having said that, colleagues, ladies and gentlemen, let me first and foremost apologize for coming late. We have so many engagement going on at the same time. And let me start from where you stopped, or also complement what you said. That is not by coincidence that there are 3 high-level health-related meetings as far as this UN General Assembly is concerned. I think that further emphasizes the fact that whether we like it or not, public health has also become a political discourse. You know, and I think it's one of the things we're learning from the COVID-19 pandemic. And when you also carefully look at the agenda for this particular 78th UN General Assembly, part of the objective, you know, is one, to strengthen health system to ensure that we have equitable, we have accessible, and we have sustainable health for all, irrespective of where you live and irrespective of your socioeconomic status. Number 2 is to guarantee a security sovereignty of all member states, especially for the low and middle income countries. Again, let's take a step back and look at our socio-economic development agenda. First, let's look at the UN Sustainable Development Goal, and let's also look at the AU Agenda 2063, especially those goals that have to do with one thing or the other as far as health is concerned. You will agree with me that we are not on track, you know, to meeting those goals. And that progress, again, has been further worsened by the COVID-19 pandemic. So, what do we do? And then what exactly are we doing as Africa CDC? We all know that every epidemic begins and ends in the community. And we know that there's no doubt about it, our community health workers ensure access to health services at the last mile, which further underscore the importance of what we are discussing here today. And as Dr. Tedros usually say, that universal health coverage and security are two sides of the same coin. And whether we like it or not, we need to strengthen our community health system, so that at the end of the day, we are able to achieve, the global security and universal health coverage at the same time. So for Africa CDC and the African Union, the Africa CDC, we are a technical institution that sits within that intergovernmental political institution called the African Union. As far back as 2017, our head of state and government have actually identified the importance of primary healthcare workforce with emphasis on community health system. Back in 2017, they did issue a declaration calling on Africa CDC and different partners to ensure that come year 2020, we should have for every 500 to 600 people on the continent of Africa, one community health worker. So meaning that by 2020, we should have 2 million community health workers on the continent, which are the backbone of any primary health care. Today, where are we? We have roughly 600,000. So meaning that we are just 1/3 of the way to the mandate or the marching order that was given to us. Number two, fast forward, COVID-19 pandemic, and the same head of state and government called for a new public health order for the continent of Africa. And underpinning that new public health order are 5 critical pillars. But I'll talk about what actually concern our discussion here today. The second pillar talk of the need to expand health workforce on the continent of Africa, including community health workers. And we have been given the marching order that we need to make sure that we achieve that declaration that was issued back in 2017, thereby calling for a lot of investment as far as the community health system is concerned. The second pillar, or the second aspect of the new public health order that has to do with what we are discussing here today, is the importance of domestic resource mobilization. Because whatever discussion we talk about, whatever call to action, we still need to finance that. And we know that partners are not going to be there indefinitely. So in the spirit of sustainability and ownership, our head of state and government, as part of the new public health order, has emphasized the need for us to mobilize resources domestically. And the fifth pillar of that new public health order, which again align with what we are doing here today, is that of respected action-oriented partnerships. We know that as far as primary healthcare is concerned, as far as primary healthcare workforce is concerned, as far as community health system is concerned, we have so many partners, so many donors, so many funders. What is lacking is alignment. What is lacking is lack of coordination, collaboration, communication, and cooperation. So going forward, the new public health order has called for the need for us to have respected action-oriented partnerships that will put the priority of our head of state and government, priority of our member state at the center of it all. Colleagues, ladies and gentlemen, Africa CDC has continued to advocate for primary healthcare as a way to attain that universal health coverage, as declared by the same UN General Assembly some couple of years back. And as Africa CDC, we continue to lead that charge. In fact, we continue to demonstrate that yes, the primary healthcare workforce can actually do it. They can support the routine essential health service and can also support the disease outbreak that our continent continue to witness year in, year out. So today, Africa CDC continue to deploy community health workers as our frontline responders. We've done that for Ebola, we've done that for COVID-19 pandemic, and we've done that for cholera as well. So meaning that with the right support, the PHC workforce can actually support us in terms of guaranteeing our security. Ladies and gentlemen, when our new DG came on board, he launched what we call the Africa CDC DG flagship initiatives, 5 of them. But let me also speak to the ones that concern our topic of discussion here today. He called for the need for healthcare workers' protection. So, and as part of this healthcare workers' protection, we need to understand who are where as far as health workforce is concerned, especially the primary healthcare workforce. So we need to have a robust database. We need geo mapping of who is where. What is the distribution? and where do we need to pay a lot of attention. He also called for the need to protect this primary healthcare workforce. Because whether we like it or not, they are the first line of defense whenever there is any outbreak. And in that regard, he has called for the need to vaccinate our healthcare workers, in line with immunization agenda 2030, immunization around life costs. As part of protecting our healthcare workers, he also called for the need to support our healthcare workers, especially the primary care workforce, with the basic personal protective equipment. You will be surprised that you go to some PHCs, you don't even have gloves, not to talk of mask, And in most instances, we discover that there's an outbreak when we see healthcare workers dying. We cannot continue like this. So we need every hand to be on deck to make sure that we protect our healthcare workers. As part of the flagship, we also have what we call the primary healthcare digitization, solarization, and connectivity. And this is mainly to support that community-based, event-based surveillance, which Africa CDC has continued to champion. We've released a couple of tools to support our primary care workforce to make sure that we get it right as far as community-based event surveillance is concerned. We've rolled out a framework. We've supported our primary healthcare workforce with training materials. We also have a scorecard that allows us to take stock from time to time of where we are and what we need to do to support this agenda. Colleagues, ladies and gentlemen, to conclude, I want to say that every outbreak begins and ends in the community, hence the criticality of primary healthcare workforce. For those places whereby we have community health workers driving this agenda, we need to salary them, put them on salary. We need to integrate them within the larger health system. We need to professionalize this primary healthcare workforce because we understand that quite in a lot of our member states, this work is done on a voluntary basis. So for us to guarantee our health security as a continent of 1.4 billion people, 55 member states, we need to ensure that we strengthen the capacity of our primary healthcare workforce. Thank you.
So I told him he can't leave. So actually, he has graciously offered to be on our panel as well. So I thank you for that. I was going to take 2 questions.
Okay.
All right. So stay right here with me. We're going to take 2 questions for Dr. Tajuddin. And we have a mic on either side. They're ready for whoever jumps first. Okay, we have a question there. How about over here? You don't want them just to ask questions. How about over here? Okay, we have a question there. Okay, or a comment. It could have been a comment.
Hi, my name's Alan Donnelly. I chair the G20, G7 Health and Development Partnership. And I'm delighted to see that finally the African Union has been invited to join the G20, and it should have happened several years ago, frankly. The thing that we are always asked in our partnership is how can we take best practice and then scale it up to other countries? And your presentation was excellent today, and thank you. What I'm really interested in is how you've managed to engage so many countries and make so much progress with your scorecards, using digital technology for frontline healthcare workers. And I would like to invite you to make a presentation to our partnership in the coming weeks and months, because what we've got to do is take concrete examples like the one that you've outlined today, and we've got to proselytize that extensively, because there are too many ministers, frankly, in governments who sit in G20 meetings and G7 meetings and UN General Assembly meetings and sign declarations, and then nothing happens. And what we need to do is take your example, and we would welcome for you to help us with this, to show that it can be achieved. So thank you very much.
Thank you, sir. Thank you. And we have another, and then I want Abuja Abuja to get ready because I'm going to see if they have a question for you as well. Okay.
Okay, thank you very much. My name is Perpetual. I work with WaterAid in Ghana, and we collaborate a lot with the Ministry of Health and Ghana Health Service to provide wash services in rural areas especially. Now you talked about protecting health workers, providing basic PPEs. What did not come out clearly for me is the provision of water, sanitation, and hygiene services. We know that for COVID-19 and all other pandemics, the one major resource you need is water for prevention. We say healthcare workers should wash their hands. Meanwhile, in our context, some do not have access to water at all. So in our planning, these discussions, how do we become intentional about this? Can we bring it forward so that we are more clear on provision of water, sanitation, and hygiene services? Thank you very much.
Thank you so much. Thank you.
All right. No, thank you. Thank you so much, my sister, Endase. Let me start with the first question. So let me say we thank the G20 community, for finally accepting African Union to be part of that family. And as you rightly mentioned, whether we like it or not, we have the socio-economic and environmental determinants of health. I think that is clear. So it's really high time that African Union become part of that G20. After all, EU is there. And we believe that surely that in itself is going to help our cause as far as improving health outcomes on the continent of Africa is concerned. And how we've been able to really be able to drive this agenda of our committed workers, digitization, and so on and so forth. When I started my presentation, I did explain the fact that yes, we are technical health agency that sits within an intergovernmental political institution. That in itself is a unique opportunity that no health agency, I don't think, has that kind of opportunity. So we can leverage at any level from the ministers to the head of state. In fact, as part of the governance structure of Africa CDC, we have at the first level the digit of MPHI, PAMSEC, and so on and so forth. Then we have the governing board of ministers of health. Then we have the High Council. These are the head of state and government, So they are part of the governance structure of Africa CDC. So meaning that whatever agenda that we want to push, all we just need to do is to inform our head of state and government as appropriate, and that surely, we get that political buy-in. And that once you have political buy-in, usually you are able to move your agenda forward. Let me also say that there are a lot of experience and learnings as far as this PhD workforce is concerned in Africa. I'm sure we all know the stories of Tedros, Dr. Tedros, the current WHO Director General. The excellent work he did in Ethiopia as far as the PhD workforce is concerned, which a lot of other countries are using as a blueprint. We are also aware of what is going on in Malawi and Rwanda, especially within that community workforce space. So a lot of South-South collaboration is happening in Africa, and these are like representative sort of setting, So we're able to really look at what has been done in one place, done very well, and try to replicate. So there is no need to reinvent the wheel, really. Now, back to the second question. Yes, we did mention that Africa CDC is working with our member states to support our frontline healthcare workers with personal protective equipment. What I did not mention is the fact that we are working with UNICEF as far as this agenda is concerned. So bringing UNICEF on board purposely is to make sure that that water, hygiene, and sanitation component of that is actually covered. I completely agree with you. You can't talk of infection prevention and control or protection of healthcare workers without water point minimum. So we're working with UNICEF in that way to make sure that the wash aspect of that, that particular area is fully covered. Thank you.
Thank you. Now I'm going to ask for a question from Abuja. I need your help over there to let me see who's raising their hand, but we're going to take one question. We're going to try to keep it brief. Does anyone have any questions, both from the audience or from the panel? I see one there. Okay.
Thank you so much for the presentation. And my question is this, because when we talk about the healthcare workers, one key thing that also comes to mind across African countries is access to health. Having these healthcare workers at the rural communities where the people are. How do we ensure that we have enough healthcare workers to be there? And when we also look at the security situation across so many African nations, how do we ensure that they are also to go to those interior villages to work? Thank you.
Thank you for your question all the way from Abuja. So in terms of ensuring that our healthcare workers actually stay at their duty positions, especially the last mile, the rural areas, let me say that this is one aspect of the whole discussion that goes beyond what Ministry of Health alone can do. This is where we need to bring other sectors on board. This is where we need to leverage the unique sort of position of other ministries, other sectors. For instance, if you put somebody to a rural area and there are all the necessary amenities there, there's every chance that that individual will stay there at least for some time. And again, you need to now bring other sectors on board to ensure that they provide that needed amenities like education, like electricity, like water, the necessary sort of security. And talking of healthcare workers protection, and I think it's part of the discussion on the PPR as far as the UN General Assembly is concerned, because we've seen what is happening in those conflict areas. We've seen what is happening in some other settings that are not necessarily in the conflict, but our healthcare workers are being targeted. So I think we need to find a way to work with all our security agencies to ensure that our healthcare workers are protected from all sort of assault and all sort of abuse. So again, it's not something that the health sector alone can do. So let's leverage the comparative advantages of the other sectors, so that at the end of the day, we have a sort of health system that has a buy-in of virtually every other sector in what we describe as the whole of society approach to health system. Thank you.
Thank you so much. Thank you, Dr. Sakatine. Thank you for being our keynote. We really appreciate it.
Thank you.
Thank you. Please have a seat, because he's going to be coming up here in no time anyways. Okay, so we now are going to bring you live to Abuja, Nigeria. And I'd like to introduce Chioma Odenye, who is the program director for our maternal child health USAID supported Momentum Country and Global Leadership Project in Nigeria. Welcome, Chioma. Am I welcoming her? Did we lose? We had her. Have no fear. I'm not dancing up here. What? We want to do the panel next then? Okay, get them back. Okay, so let me introduce Chantel. Chantel, I'll let you take it from here.
Oh, okay, that's fine.
I'll let you take it from here.
Well, this is incredible. When you plan an event for days and days and weeks, and all of a sudden it's here, it's extra magical. But thank you for being part of this very special event. And I'm going to start off, I'm going to be the moderator in New York today. And I'm very happy to introduce myself. I'm Chantal Allen. I'm the Senior Principal Technical Advisor for Primary Healthcare at Jhpiego. And I will work with Chioma when she comes online. And we will work together to bridge this divide, the virtual divide, so that we can have our two panels have a conversation together. So I'm going to start by inviting the New York panel up. And I'm going to start first with Dr. Nida Ramawati, who is a representative from the Ministry of Health in Indonesia. If you don't mind coming and sitting on the end over here, that would be wonderful. She's the Director of Productive Age and Elderly Health at the Directorate of Nutrition and Maternal Health at the Ministry of Public Health in Indonesia, and she's been a public health professional for more than 25 years. Dr. Nida focuses on maternal and child health and has also been really interested and invested in early childhood development. Thank you for being with us today.
Thank you.
We will have Tracy McNeil, who will join us shortly, but I'm going to go ahead and oh, here we go, Tracy, welcome. Tracy, only a nurse would be willing to fly across the country, get off the plane and be fabulous.
That's very kind of you to say so. I'm sorry, I'm a few minutes late.
Perfect. So Chioma, I'm going to continue to introduce our panel and then I'll hand over to you. So Tracy is the Director of Primary Healthcare at the Bill and Melinda Gates Foundation. And before that really was instrumental and played a key role at Jhpiego in Rwanda, and also was the Senior Vice President at Mary Stopes. So thank you so much, Tracy.
Pleasure, thank you.
And Lauren, if you don't mind joining us on the stage, please. So Lauren is the Vice President of Global Community Impact at Johnson & Johnson's Center for Health Worker Innovation. And Lauren is responsible for driving strategy development and implementation of Johnson & Johnson's social impact work. Lauren also leads many other parts of the foundation, including being the president of the Patient Assistance Foundation. So thank you so much, Lauren. And Dr. Tajudeen, thank you for agreeing to be on our panel here this morning. So Chioma, over to you.
Thank you, Chantel. Good evening, Abuja. Good afternoon, New York. My name is Chioma Oduenyi. I work as project director at Jhpiego, Nigeria, and I'm delighted to be your moderator in Abuja this evening. Sitting with me up podium here is a team of incredible primary healthcare workers, and I will start by introducing them. At my extreme right, I have Triveni Pitamba. Triveni has come all the way from India. She's the community health officer at the B. Nuagam Health and Wellness Center in Odisha State in India. For the last 3 years, she has led the primary healthcare team and is responsible for implementing some of the government's primary healthcare initiatives. Some of these include telemedicine, mass health campaigns, and supportive supervision. Triveni, you're welcome on the panel.
Thank you.
Yes, let's give it up for her. Next, seated next to me is Roger Zingri. Roger has come all the way from Burkina Faso. He's a qualified state nurse in charge of primary healthcare center at the Bolemba Health Facility in Burkina Faso. He has more than 17 years of practical work experience, including working as head nurse for the last 14 years at several health centers in Burkina Faso's Southwest region. You're welcome on the panel. Roger.
Okay, merci. Okay, merci.
Let me move over to my left. I have Edith Nka Okoro sitting directly beside me. Edith has come all the way from Ebonyi State, Nigeria. She's a registered nurse working at the Model Primary Health Care Clinic in Isiaka in Obinago, Ebonyi State in Nigeria. She has more than 10 years of experience, and she's the focal person for reproductive health, maternal, perinatal, child health surveillance response. She's the focal person for quality improvements and gender-based violence at her health facility. Edith, you're welcome to the panel.
Thank you very much.
Last but not the least, on our panel from Abuja this evening is Vivian Oluchukwu. Vivian is a community health extension worker at the Victory Hospital and Maternity in Delta State, Nigeria. Vivian has spent more than 6 years tirelessly serving her community. She travels throughout the region, talking to people, especially school children, about healthy living habits and she serves as a bridge between healthcare facilities and the community, offering culturally sensitive care and fostering trust. Vivian, you're welcome on the panel.
Thank you, Ma.
Over to you, Chantel.
Thanks, Joma. So today we're going to engage with our 4 health workers, and we're going to use their lived experience to help guide our panel discussion today. And what we know that their stories will illustrate is really that they provide care to real people and families beyond diseases and sickness. They partner and engage with their communities to invest in improving community health. They are truly the front line and the first response to outbreaks and epidemics and emergencies. But what they'll also highlight is they need our support. They need to be integrated and supported within the health system. And so today we're going to start from the beginning, and we're going to start, Roger, with asking you to share your experience of what does providing primary healthcare services look like for you in your community.
OK. Pour les soins de santé au Burkina Faso, je vais prendre un exemple. Rien que quelques semaines de cela, j'étais de garde la nuit et que j'ai reçu une femme enceinte qui est arrivée, qui saignait et qui avait mal partout. J'ai vérifié la température était élevée et j'ai immédiatement pensé au paludisme. J'ai essayé de faire le test rapide de diagnostic qui a effectivement déterminé qu'il s'agit du paludisme. Donc, j'ai procédé au traitement. Et il faut reconnaître que chez nous, la formation sanitaire de base, comme le nôtre, c'est le premier point de contact de la population avec le système sanitaire. Nous prenons en charge plus de 90%, nous prenons en charge plus de 90% des cas au niveau périphérique et les 10% sont référés au CMA, qui est l'hôpital du district. Il faut reconnaître que la population gagne en venant se faire soigner. Tout ça a commencé par la sensibilisation. Il faut d'abord sensibiliser la population, leur faire comprendre l'importance de se faire soigner à temps, et dès lors qu'ils sentent les premiers signes, ils viennent au CSPS pour se faire soigner. Et il faut reconnaître aussi qu'il faut aussi avoir la confiance et la sécurité. Nous, c'était cette confiance et cette sécurité, et cette dame n'allait pas venir se faire consulter, et le paludisme qu'il avait, il pouvait perdre son enfant facilement. J'en ai terminé.
Some weeks ago, I was on night duty when a pregnant woman came and complained of body pain and bleeding. I suspected malaria and tested her, took her temperature, and then eventually the result came positive that she was suffering from malaria. I gave her the appropriate treatment. I need to tell you that in our community, the primary health center is the first point of call, and that is the bridge between the community and the health system. In fact, we take care of 90% of cases. There's only 10% that we normally refer to the general hospital or the nearest hospital. Generally, also, we sensitize the community on the good habits, good hygienic conditions, and then we let them know that whenever they have problems, they should come early. In the case of this woman, if she didn't come early to the primary health center, she should have maybe lost her baby or probably die. Thank you.
Thank you very much, Rogers, for that example. This highlights how you're providing high quality primary health care to everyone in your community. Riding on Rogers' example, I'm going to be taking us over to New York. And I'm going to throw my first question to Tracy. Tracy, riding on what Roger has said, the Bill and Melinda Gates Foundation have been supporting country governments in their efforts to provide high quality primary health care to citizens. Can you share with us some of the examples that are promising in primary health care that you're seeing at your foundation? And what are your foundation's priorities for supporting primary health care? Over to you, Tracy.
Great, great. Thank you, and a great question. And first of all, on behalf of the foundation, it's great to be here today and to see so many of you. And how amazing to be connecting with our colleagues in Abuja. So thank you for giving us this opportunity. I guess I think it's a really exciting time in primary healthcare. And one of the first things to say is that the foundation now has a strategy in primary healthcare, which it hasn't had for a number of years. The foundation, as you know, has worked in verticals, but for the first time, we had a primary healthcare strategy approved 2 years ago by Bill and Melinda Gates themselves. So we're very committed now to health system strengthening, and we have a whole team that's working in that way. Our strategy is really divided into 4 areas to come to answer the question in the work that we're doing in the foundation. So when we were developing the strategy, what we found, and when we were looking for proof points and exemplar work around how you can create the best outcomes in primary healthcare, then foundational reforms and health financing is one of the main pillars. If you can get money flowing to the facilities, a level of accountability and autonomy at a facility level, then that's where we see the best outcomes improvement in performance, coverage, and much better performance data. So 60% of our work is really centered around foundational reforms. The other part of our work, which is very relevant today, is around, we're calling it the innovation agenda. And that's really because we have an interest in digital health in the foundation. I think when we look across primary healthcare, there's so many digital tools that are now available and digital data. And so for the foundation, we're focusing in 3 key geographies where we believe that we'll learn a lot. It's a learning agenda for us. And also, whilst there's exemplar data on primary healthcare performance, there isn't the same exemplary data around digital. So also what we want to do is learn through our partners, our implementing partners, and through our key stakeholders about how digital can be transformational, understand the challenges, and then work with global scaling levers to scale that work. And so some of the examples of the work working on at the moment, and I'll start with Nigeria because our colleagues are here, I was in Abuja a few weeks ago, and also Lagos. So one of the things we're doing in Lagos was I saw one of the best primary healthcare facilities within the public system in Lagos that is fully digitalized from end to end. So the patient walks in, if they've been there before, they're already registered, even down to a waiting list and a queuing system in the waiting room. All the health providers' notes are contemporaneous, and they follow the patient around the facility. And you can also do follow-ups. So we're really excited about that. It doesn't at the moment cover maternal and child health, so we're helping build that module, which will be very easy to bolt that on. But the reason we're doing that in Lagos is that's our starting point, it's not our end point. And we feel excited by the opportunities that this technology provides, that is a private sector tool, but being implemented in the public sector, is that then when, recently I was in Kano, for instance, is that you can really see the value in working with remote communities where access to primary healthcare is not how we'd want it to be. So I think, that's one very good example. On Friday, I was with Minister Budi, the health minister from Indonesia. I'm sure there's probably some of his delegation in the audience today. So welcome and good to, sorry, the light's not very good here. I do apologize. So, and we had some really great discussions. And so we're doing, again, what I think is important work. So the Ministry of Health in Indonesia, they have a real problem because their geography is a real real issue with 17,000 different islands. And for some reason, I can't actually get that metric out of my head because I'm from the UK and we live on one island. So 17,000 is pretty impressive, but very challenging. So again, we're doing work equipping frontline workers, community-based health workers with digital tools. And we also think that if you link that to telemedicine, that will be we'll learn a lot in getting the last mile with remote populations. And I guess the final example I will give is in India with Jhpiego. So they've been incredibly successful because there's very high stakeholder engagement with the government of India providing telemedicine. And it's really, really scaled to millions and millions of consultations. But often what happens, and I learned a lot about this when I was working in Rwanda, which you mentioned earlier, with Babylon, developing a completely comprehensive digital first solution in Rwanda, is that if you just focus on scale, then quality gets left behind. And then it's really hard to catch up again. And so I think, and we're seeing that in India. And so it's an exemplar in terms of scale, but we're now working with the government around clinical audit tools, peer review, some scripted conversations. And when we did a deep dive into the work, and we've been working with Jhpiego there, is that consultations were lasting 30 seconds or 24 hours. Now, 24 hours was because the consultation wasn't closed off, it was left open, so that's a clinical risk. And obviously doing a consultation in 30, 60 seconds, we know is not long enough. So I think there are a few examples of the work we're doing. We're excited about the opportunity. I think it's a great time. I believe the time is now. I don't believe in pilots. I've banned the word pilots because the world is awash with pilots. So we talk about pre-implementation phases because then it gives us all an intention that we're going to learn and then we're going to scale. So I think we've got good reason to be excited. Thank you to our partners who work really hard in the field implementing and allow me the opportunity to talk about the great work they do. So thank you.
Thanks, Tracy. I think what you've done so eloquently is to really talk about how we need to improve the quality and access of services that we deliver. And really that service delivery package of primary healthcare is often where our minds go first. But what's really an important part of primary healthcare is also the community component. So I want to ask Triveni to share with us this afternoon a kind of brief example of what that community component of primary healthcare looks like. What does it look like to engage with and build on partnership with community to improve health?
So community engagement is an important part in primary healthcare services because we are involving community with the healthcare facility so that we can build up trust along with the people and we can understand their health needs so that we can provide them better healthcare services. So in India, we are having a locally healthcare management system. This committee, it used to plan and monitor the healthcare facility so that we can provide better healthcare services to the community. The problems that the community is facing in case of healthcare services, it has been identified the committee and it has been resolved by the committee itself. So this committee, it used to help me in raising and allocating funds and solving out the problems that has been identified the community. Because in India, we are the first healthcare facility. We are the first point of care where people used to engage with us. So community ownership and engagement is quite important to provide quality healthcare services to the people at the grassroots level. Thank you.
Thank you very much, Triveni. The importance of community engagement cannot be overemphasized. And it's even more interesting to see that the government of India is prioritizing universal health coverage through investment in primary health care, being one of the health agenda of the government. And we know that Indonesia is also prioritizing primary health care. And riding on Triveni's submissions, I'm going to move us again back to New York. And this time, my question will be going to Dr. Nida. Dr. Nida from the Ministry of Health, Indonesia. Dr. Nida, the government of Indonesia is prioritizing primary health care, and you're already moving from policy to implementation with bold actions. Can you share with us what your government strategies and priorities are? Over to you, Dr. Nida.
Thank you. Good afternoon, everybody, and good evening for the panelists from the Abuja. First of all, I would like to extend my gratitude to Jhpiego for giving us time to share the experience of Indonesia on health worker in primary health care. As we know, the lesson learned from COVID-19 pandemic, the primary health care and also the readiness of the community is very important to build the resilience of the community. And therefore, since 2020, the Minister of Health, Mr. Budi Gunadi Sadikin, has been having initiative to make the health system transformation. There are 6 pillars of health transformation. First, the primary health care transformation. Second, the referral services system. The third, health resilience. The fourth, about the transformation of health financing. And the fifth, human resources. And the last one is the technology in health system. And for the primary health care, we restructuring the networking and also the role of the community and the health worker. We integrate the many community health posts, like a Posyandu integrated health post. There are around 3,000 integrated health posts at the around 83,000 villages in Indonesia, and each integrated health post conducted by 5 cadres minimum. And we already developed the module to increase the capacity of health worker for 25 capability based on the life cycle for the educate and counseling and services for the child, adolescent until the elderly. And also we strengthen the auxiliary that below the public health center. And also we strengthen the public health centers. It's around 10,000 and 3,100 public health center in Indonesia, along with the laboratory system. So the surveillance of the emerging diseases, we strengthen the capability of healthcare to identify the new emerging disease, and also it's supported by the digitalization of health information system. So the primary healthcare is very important and become the foundation of all the health system. First sub-pillar of primary healthcare transformation is educate the community, and the second is health screening of all age group of life cycle, and then to improve the health, like immunization, giving vitamin A, iron tablet, and also we integrate all this for the 5 pillars, including the health financing. The fund directly transferred to the public health center from the Ministry of Finance, even not through the Ministry of Health, directly to public health center at the sub-district level. So they can manage, and we have the monitoring system for this primary health care.
Thank you so much,
Yeah.
Dr. Nida. What I love about those two examples is it really highlights this incredible global recommitment to primary healthcare that's happening on very exciting levels. Countries are reinvesting and reprioritizing policies, and donors are aligning to those priorities. It is truly an exciting time. So let's pivot our conversation a little bit now to COVID. So we're getting closer to our conversation around, we've set the foundation of primary healthcare. We've seen it as a priority moving forward. Let's reflect a little bit on COVID-19. And so let's start, Edith. Let's pivot to you. And Edith, in Abuja, do you mind sharing us an example of what was it like in those early days of COVID-19? We've moved so quickly, but it really was only 3 and a bit years ago. What was it like in those early days? How did you experience providing care? What were some of your challenges?
Health workers who work in the primary healthcare setting make challenges in every day of our activity. All to the fact that in the setting where I work, we have no light, we have no water. Storing water in the tank is the only source of water supply, and we are short-staffed. In my facility, we have just 3 healthcare workers. So when COVID-19 set in, that was what we have, and that was what we were working with. And that made things very complicated and stressful for us. The most challenging I encountered was people's belief. People generally believe that COVID-19 doesn't exist. And so it was very difficult. People do not adhere to the safety precautionary measures. Wearing face masks, washing hands, people could not adhere to that. And so we were attending to people with the fear of being infected, not being infected. We meet people with these signs and symptoms, but then we could not stop giving care. Even though we are less protected, but we could not stop caring for our clients. We keep caring for our clients, even though we are not protected, having the fear that we will not get infected. So it was very stressful and it was challenging in those days. Thank you.
Yeah. Thank you very much, Edith. I'm sure we can all relate with Edith's story. And the high point is that in the midst of all of that, they are still providing care. So thank you for the incredible work that you're doing in the face of the challenges that you are facing. And this goes to show us the challenges that healthcare workers face while delivering services, both personally and professionally. And riding on this, I'm going to move us again over to New York. And this time, I will be directing my questions to Lauren from Johnson & Johnson. Lauren, I'm sure you have heard Edith loud and clear. And based on your experience and your work that you do at Johnson & Johnson, how might we better support healthcare workers? Frontline healthcare workers like Edith. What strategies have been successful? And how can we take some of the successful strategies to scale? Over to you, Lauren.
Thank you. Well, let me start by saying I have a lot of humility being in a conversation with Edith and the health workers in Abuja, as well as many of the health workers in the room, who I think are doing the hard work. And as much as we can learn from you and understand the role that we can play, I do think the private sector plays a role, and Johnson & Johnson is one of the largest healthcare companies in the world, understanding sort of the role that we can play. And I will say a couple of things and bringing the pandemic top of mind. As the pandemic was literally just starting, we had just made a major announcement. We've dedicated resources and support to frontline health workers for decades at Johnson & Johnson. But we kind of looked at all of our different programs and practices and strategies and said, we're actually going to put the frontline health worker front and center and say, if we want to increase access to primary care, If you want to support primary care and equitable health systems, the frontline health worker is going to be our focus, sort of the human at the heart of care. And that if we could solve the challenges facing frontline health workers, we increase health for everyone. And Dr. Tujijin, I was interested to hear you talk about access and equity and sustainability, because I think those key concepts are so critical here, where at Johnson & Johnson, while we put that health worker at the center, trying to understand, aligning with other funders and donors around some of these key concepts, understanding that a lot of one-off things isn't going to make a lot of sense, and how we come together, whether it's a geographic priority, partnering with the government and the health minister, understanding that we need the support so that they are paid and recognized. We have a whole area on resilience, which I think we learned a tremendous amount during the pandemic, with health workers all over the world, especially in low and middle income countries, not having the support for their own mental health and well-being in order to care for their communities, and how we could bring expertise there. And so by putting the health worker at the center, our primary focus areas are around learning and development, making sure that the frontline health workers are at the decision-making table. Of course, the government and the health ministers leading the way with us as supporters, but where we can bring learning and development, looking at some of the innovative health models, digital health, digital technology, where that can make sense to play a significant role. And I would say also sort of using our voice and advocating on behalf of health workers. I think that's one area the private sector can play a role, to use the big voice of the company to make sure people are more aware of these issues and the role that we can play. And again, that critical role they play, really that human at the heart of the system. If we don't have frontline health workers providing that access and that expertise to primary care, you sort of don't engage with the rest of the system. And so as much as we can sort of shine a light on that, and then we've got a few great examples. We're proud of the work that's happened in Kenya, where we played a role to make sure the funders were together working with the government through a collaborative system, really a convening around everyone bringing the best assets to the table. And I think that's where the funders and the investors can come in to learn what's really local, what's working, and then really how we can be a support for that work going forward. So I love the conversation. I agree that I think it's time. It feels like, I remember when we announced in January of 2020, we're doubling down on the frontline health worker. We thought we would spend a year or two making sure people understood the critical nature of health workers, and then COVID hit. So I like to take credit that we were really prescient in understanding, but we just sort of at the right time said, we got to be here, we got to put it all in here. And of course, it's an ongoing journey, but we're really proud to be part of the conversation and appreciate Jhpiego and Last Mile Health inviting us to the conversation.
Thank you, Lauren. I think what you're saying about the frontline health workforce is really important. And at Jhpiego, we really believe that community health workers are part of that, of the primary healthcare team. And so at this stage, I'd love to ask Vivian from Abuja, if you don't mind telling us, sharing your experience of what it was like to interact with the community and to address some of the challenges at the community level as a community health extension worker or a community health worker. Thank you, Vivian.
Like my colleague said here, Edith, that it was a challenging one, working in the community, health educating them about the COVID. Some people were saying that it's against their religion, it's against their belief. And some people were saying they were taught how to use ginger, garlic, and hot water to clear their airways on the COVID, that it will not affect them. But we did not rely. We continued to health educate them on the importance of taking vaccines to protect themselves against COVID. So in as much as we continued from there, we went on to the universities where we met with some students, we health educate them, and we use ourselves as typical example that looking at us, we all have been vaccinated with the COVID vaccine that is not harmful in as much as the vaccine is given to you.
and you have feverish condition is normal. It shows a sign that something is going on in your body. That it means that something is given into your body to protect you. So we try as much as using that technique. And another technique that really wins more students to come out to come and take the vaccine is telling them that if you don't get this vaccine into your system, you don't have the vaccine cards, there's no way you can japa out of the country. So it was mind-blowing, and we really get to get enough students, people to come out and really take the vaccines. And through that, we were able to gather much people to take the COVID vaccine and for them to complete the vaccine process. Thank you. Again, thank you very much, Vivian, for the incredible work that you're doing. And I'm sure we all resonate again with Vivian's story. Oh, yeah. During COVID, we had a lot of misconceptions of ginger and garlic solution. But this also illustrates the importance of community health workers in the whole care around primary health care. So they do a lot of work, not just in supporting routine services, but they're also there to support during emergencies. And evidence have shown us that this cadre of health workers are very critical in the primary health care structure. With this, I'm going to go back again, and I'm going to continue with Lauren. Lauren, we understand that Johnson & Johnson has been doing a lot around community health workers. As a matter of fact, it has been an important part of your commitment to frontline health workers, supporting community health workers. So from your experience, would you share with us what strategies that are needed to support community health workers, and how have you been supporting these initiatives from your foundation? Over to you, Lauren.
Yes, well, I'm happy to share a little bit more and making sure that my colleagues have a chance as well. I would say that community health worker, we really do perceive as the access into primary care, and the community health workforce, along with nurses and others, and making sure that they have, back to the ideas around access and really the education, the support that they need, the digital health technology. And so I would say the primary approach is really understanding, I mentioned geography, sort of what places where the health minister, the government are sort of interested in partnering and working with other funders, other stakeholders. I won't say the word pilot, but where we can learn, what's working along with others. It's one of those fabulous areas where we're not competitive with each other. We all want to learn sort of what is working best, including the NGO colleagues in the room. So sort of understanding what's working. I mentioned our example in Kenya and where we can take those learnings and bring them other places as well. There's a number of different, we're working in Indonesia and other areas. We also talked about aligning around capabilities. Are we helping to deliver, making sure we understand the skills and capabilities that are required, professionalizing. I hate to say that because it sounds like they're not professionals, but I think you know what I mean as far as what capabilities can we help bring to the table to make sure that they're really able to deliver their work in the way that they want to? How can we protect them from disease outbreaks? How can we use digital technology to align against those sort of skills and resources, both in their hands to learn, but also as we're tracking diseases and other important items. So I think the idea that we look at some of these models where it's working, partnering with the government and health ministers who are ready to sort of try to move and improve, and then really where can we play a role in trying to help make that happen, again, with a lot of humility that the local teams really are the ones who have the answers. We're just here to try to support.
Thank you, Lauren. And it really, what you were saying really kind of amplifies Raji, what you were saying earlier about the CDC's strategy. So our conversation so far has really established primary healthcare, really that recommitment. It's really, COVID helped us reposition frontline health workers as being front and center and really important. And now let's look forward to pandemic preparedness and response. And as to my panel, as we're running out of time, we're going to ask our team to make your examples a bit succinct, if that's okay, so we can get through everybody. But we want to acknowledge the fact that our frontline health workers are responding to pandemics beyond COVID. I think we've highlighted COVID, but really they are the frontline response. And we wanted to give our panelists some opportunities to share some of those examples with you. So Roger, maybe starting with you, if you could provide us a short example of how you've responded to an outbreak in Burkina. What did it look like and what was your experience? So Roger, over to you in Abuja.
OK. Ce qui concerne les pandémies, généralement, les pandémies sont temporaires. Ne sont pas permanentes, sont temporaires. Je prends un exemple de l'épidémie, je prends un exemple de l'épidémie de méningite. Généralement, dans ma communauté au Burkina, là où je sers, la méningite intervient généralement commence généralement dans le mois de janvier. Voilà. Donc, nous travaillons avec des agents de santé à base communautaire qui sont un maillon très important dans la sensibilisation. Ils sont déjà formés sur les signes de la méningite. Je prends un exemple terre à terre. La saison passée de méningite, un agent de santé communautaire qui était en visite à domicile, qui part tomber sur un malade qui est couché, qui ne se sentait pas, mais qui ne voulait pas venir à l'hôpital. Il a essayé de sensibiliser le malade de venir à l'hôpital, le malade a refusé. Directement, il est revenu à la formation sanitaire nous voir. On est parti voir le malade. Dès lors qu'on a vu le malade et qu'on a négocié, le malade est venu, on a fait les prélèvements envoyés, il s'est avéré que c'était la méningite. Donc, on l'a isolé, on l'a isolé et puis procédé au traitement. Et maintenant, convoquer les coutumiers et les religieux, qui sont les leaders communautaires, y compris les agents de santé communautaire, les sensibiliser sur les dangers que nous courons avec l'épidémie qui veut commencer. Donc, en même temps, on a sensibilisé les leaders de dire à la population de ne pas venir rendre visite aux malades parce que c'est leur habitude. Une fois qu'il y a un malade à l'hôpital, ils sont les premiers à venir rendre visite aux malades. Et qu'il y a un système aussi, il y a les funérailles. Nous avons des coutumes, les funérailles durent 3 jours. Donc, ils faisaient les funérailles, ils exposaient le corps pour faire les funérailles pendant 3 jours. Vu le danger, nous les avons sensibilisés de mettre fin aux funérailles. Dès lors que quelqu'un meurt, on enterre directement et on met fin aux funérailles. Voilà. Donc, une fois qu'on voit que l'épidémie prend de l'ampleur, on fait appel maintenant au ministère de la Santé qui vient avec la vaccination pour mettre fin à l'épidémie. J'en ai fini.
In my community, apart from the pandemic, we also have some cases of meningitis, especially during the month of January. Let me take an example. Recently in January, a health worker heard that somebody was sick. He went to his house to see him. And then he realized that he didn't want to come to the hospital, to the health center. He talked to him, he didn't agree. And then we all went back to see him. We convinced him to come for treatment. After testing him, we realized that he had meningitis. So we treated him, we isolated him, and we embarked on sensitization of the community. We involved the traditional and religious leaders to talk to them so that they can avoid the spread of the disease. For example, in my community, when somebody dies, the corpse is kept for like 3 days for funeral, and people will be around, they'll be gathering there. So we sensitize them, we advise them against, for example, visiting sick people at that period, or burning dead people immediately after they are dead. And then we also advise them to also avoid gathering in large number during burials. Those are the type of things we do in order to reduce the spread the spread of the disease in the community. Thank you.
Again, thank you very much, Rogers, for that example from Burkina Faso. This illustrates an epidemic-ready primary health care that identifies and responds to emergencies. I think this is similar to what is obtainable in several other countries. And I'm going to take my next question back to Dr. Nida from Indonesia. And Dr. Nida, riding on what Roger has shared with us, could you also tell us how you're making such response a reality in Indonesia? And also share with us some recommendations that you might want other countries to take a cue from. Over to you.
Yeah, thank you. Surveillance is the important role for the pandemic preparedness and response, including in the community. So we should improve the surveillance system in the primary healthcare, involving the healthcare provider and also the cadre. Because as you mentioned that Indonesia has more than 17,000 islands, so it's very hard for healthcare to monitor what happened in the community. So the extension of healthcare we improve the health cadre to identify the cases in the community and also strengthen the health information system through the early warning and response system. So there is an alert in the health early warning and response system. The health care services should take an action within 24 hours. So for the pandemic preparedness and response, we involving the health cadre in the community and also strengthening the digitalization of early warning system and also the laboratory. Yeah.
Thank you, Dr. Nida. Thank you. So to the Abuja team, I'm warning you that I'm going to go way off script now. So we're running out of time. So Chioma, I'm just going to jump ahead and I'm going to just moderate the next couple of questions to the panel in New York, because I just want to make sure that we have a couple of key questions. And so it's Chioma, I'll keep updating you on where we are. But I think what I'd like to do now is to really pivot and ask Raji. As you can hear, we've kind of taken this journey to really position frontline health workers as being critical to not only primary healthcare, but being the foundation of pandemic preparedness and response. And I'm sure what you've been hearing from the stories is what you were talking about earlier on around community surveillance and community-based surveillance being so important. Just thinking about your work and thinking about your work and reflection across the 55 member states of the AU, any reflections on recommendations for countries as they're strengthening community-based surveillance, and how do we keep our frontline health workers as central to that conversation?
No, thank you, moderator, for that question. So let's take a step back and look at the continent of Africa. Today we have repeated emerging and re-emerging infectious diseases as far as the continent is concerned. We've seen Ebola from West Africa, we've seen Ebola, DR Congo, we've seen COVID-19 everywhere, we've seen mpox, we've seen Lassa fever, then we've seen cholera ravaging about 14 different member states. So all these underscore the need to strengthen surveillance at the primary healthcare level. So in this regard, about 5 years ago, just a year after Africa Cities came on board, we launched our framework, for event-based surveillance, So at that time, we were working just at the national level. But given the experience we've learned over time, we decided to go sub-nationally, and this time around using the primary healthcare as our entry point. And so in that regard, we outline some couple of approaches. So one was to develop tools that our members will be able to adopt and adapt as appropriate. So we launched a framework, that will allow and guide our member states on how to go about the community-based surveillance, so that the early warning system, the risk assessment, the prompt diagnosis, and ability to respond. Not only that, to also digitize that system so that whatever data that is coming in is real time. Because if you look at the content of Africa, most of our member states rely on this DHIS2. And DHIS2 for most of our member states is stopped actually at the district level. It doesn't go to the PHC. So what Africa CDC plan to do is to make sure that there's that linkage between the district level and the primary healthcare. Because the first point of contact is actually the primary healthcare. So that's the second. The third part of it is this training. Today we have the field epidemiology training program on 3 levels: advanced, intermediate, and frontline. So what we are pushing for is that the frontline training, which is just 3 months, and you can train up to 4 rounds in a year, should target the primary healthcare workforce, in such a way that they have the skill, they have what it takes to be able to pick whatever that is going on in their community in a very timely manner. Currently, it takes around 10 days between when there's a outbreak and when there is contact with the system. But how do we ensure that we shorten that to what Resolve to Save Lives is already preaching, the 717? So really, we're working with a lot of our member states in that. Number 4, we're also creating this community of practice, that we allow people to share experience between the different member states, so that you don't need to wait for what USCDC is putting out there, before you know how to do your surveillance. You have a lot of good experience from Rwanda, good experience from Ethiopia, that can be replicated in a place like Nigeria, in a place like Burkina Faso, and so on and so on. So that community of practice is key. Number 5, investment at that level. So part of what the COVID-19 did was to set up what we call the COVID-19 Commission, chaired by one of the head of states. And one of the tasks of the commission is to ensure that there's appropriate investment in health workforce, and primary health care is one key component of that. So we mobilize a lot of partners to be able to really ensure that we channel our resources as appropriate as possible. And last but not the least is what I call that coordination, that collaboration, between the different partners and also between the different sectors. Because if there's anything the African Union is able to do, is to convey beyond the ministries of health. We can bring all the relevant stakeholders together to ensure, that we are able to build the capacity at that primary healthcare level, so that truly and truly they can serve as the first level of defense when it comes to emerging and re-emerging infectious diseases. Thank you.
Thank you. Thank you so much for that. I think in wrapping up this kind of part of our panel, we did a number of interviews with health workers over a number of weeks. And we really felt like this last story we wanted to share with you as really the sum up of why primary healthcare is so important. And so Edith in Abuja, if we can ask you to share an example of why primary healthcare before, during, and with pandemics is so incredibly important. So Edith, thank you.
I went for an outreach in a community, a Kembe community, where we conduct an outreach program. There, I met a physically challenged young woman who opted in for HIV testing. And after counseling and then the test result came out, and fortunately it was positive. And then she personally confided in me that she willingly opted in for the pregnant, because at that particular setting where was coming from, when a young woman died without having a child, she's seen as unfulfilled, and sometimes she's even buried outside her father's compound. So she wants to at least feel fulfilled, and that was why she opted for that pregnant. And looking at her, she's physically challenged, she's HIV positive, she's not married. It was so empathetic. So I was really, really feeling for her, and we took up her care, keep caring for her, follow up in her antenatal services, enroll her on ART treatment, and then at the end, this woman did not only come out having a successful delivery and then looking healthy, she came out with a HIV negative baby, and she was very happy. She feels fulfilled, and I feel we've made an impact in her life. Her story changed. Now she's living with her baby, and she feels very, very fulfilled in life. And so I feel with this little effort we put into her, and we've really achieved something. We've really make an impact, and we've really make her life have another different story. I think with that, we made an impact in her life. Thank you.
Let's clap for Edith. Thank you very much, Edith. So this, what she has just shared is a testament of the incredible work that primary healthcare workers have been doing, helping in our communities, working for all of us, treating their neighbors, everyone in the society, in the communities. So we appreciate all the work that you have been doing. And on this panel this evening, we have heard from Triveni, we have heard from Roger, we have heard from Vivian, we have heard from Edith. All that they have submitted this evening goes to demonstrate how important that sector is, primary healthcare. They don't just treat diseases, they treat people, all of us inclusive. And they continue to draw on trust to engage with their communities, to make their communities healthy. And this calls for collective support to the primary healthcare system. They need our support. We need to integrate them into the healthcare system. And of course, they have also demonstrated that the frontline health workers remain the first point of call when it comes to prevention, when it comes to response. And with that, I want to sincerely thank all of you, and also thank our panelists over there in New York. Thank you so much. Let's give them a round of applause. And I'm going to turn back to Chantel. Chantel, over to you.
So we do want to give the Abuja panelists the last word.
As you should.
As we should. And we know that all of you that in the audience and our panelists here, you're going to be participating, you're going to be representing your organizations and these incredibly important topics. And so what we want to do is we want to give an opportunity to our 4 panelists in Abuja, their recommendations for what they feel is important for you to take forward into those meetings. What should we be asking for to strengthen primary healthcare? What should we be advocating for universal health coverage? How do we keep frontline health workers as part of the conversation? So really quickly, I'd like each one of our panelists in Abuja, what is your ask? What do you want to ask this audience and these panelists to be advocating for on your behalf? So I think Triveni, starting with you.
In this evening, I would like to request if we could have more healthcare providers at the grassroots level, then we can provide better primary healthcare services to the community. Thank you.
Thank you, Triveni. Roger.
OK, à ce qui concerne le Burkina Faso, généralement, ce que nous avons besoin, c'est le matériel médico-technique et un accompagnement dans la formation continue des agents de base, des agents communautaires. Merci.
In Burkina Faso, what we need, first of all, is material support, medical equipment, to help us perform effectively. And we also need capacity building. We need to be well trained so that we can discharge our duties effectively. Thank you.
Thank you, Roger. Edith.
Okay. What we need is, we want our healthcare system, primary healthcare system, to be well equipped. I think if we equipped our primary healthcare system, the healthcare provider will work in a conducive environment and they'll be able to put in their best. Thank you.
Thank you, Edith. And Vivian.
What I would want to put in is training of the health workers and also giving choose voice to speak globally. I think is very, very important to me. Thank you.
I think you've heard your call to action, and thank you on our panel's behalf on moving forward. So I'd like this panel to stay seated, and James, if you don't mind closing us off this afternoon, thank you.
Good afternoon and good evening. I'm James Nardella. I serve as the Chief Program Officer at Last Mile Health, and it's a great pleasure to co-host this event with our friends from Jhpiego. So let me begin with a word of thanks to our 8 panelists and our moderators, Chioma and Chantel, for bringing these diverse perspectives to the fore. Thank you. And thank you to the communications teams at Jhpiego and at Last Mile Health. I know pulling off an event like this takes a whole army, especially when there's live streaming involved. So I just want to breathe a big sigh of relief and say we're so happy that this has all worked. So thank you. It added a little suspense in the room, and so I'm grateful that it all turned out. So let me just say that today's voices made vivid for us the need and opportunity to bring integrated primary health care as close as possible to the communities and patients. Roger from Burkina Faso, you reminded us of the urgency that we must help community members when they are suffering, no matter what. Edith from Nigeria, you echoed that deep commitment to providing care even in the early and scary days of COVID-19. Triveni from India, you highlighted that community engagement is essential to increasing trust and improving services. Vivian in Nigeria, you bore witness from your own experience that community health workers are especially well-suited and well-placed to be that trusted link to health services. Thank you all today.
Thank you.
At Last Mile Health, we exist to bring a health worker within reach of everyone, everywhere. Alongside our ministry partners in Liberia, Ethiopia, Malawi, and Sierra Leone, we have supported 12,000 community health workers who reach nearly 12 million people. Experience and evidence has shown us that when we invest in those closest to the problem, closest to communities, community health workers like Vivian, and we ensure that they are skilled, supplied, supervised, and salaried, that they can improve health outcomes and health equity for their neighbors in remote and rural communities. Community health workers can maintain routine care during crises like Ebola and COVID-19, and during the everyday health crises faced by people with inadequate access to healthcare. This is why at Last Mile Health, along with partners, we've championed the Monrovia Call to Action and teamed up with the Global Fund and partners like Africa CDC and Johnson & Johnson to increase the availability, design, and durability of funding for community health workers in 10 countries starting with a $100 million catalytic fund at the Global Fund under the banner Africa Frontline First. So let me leave you with a bit of a benediction. As we leave today and step back into the rhetoric and deal-making of UNGA, may we all keep the lived experience of frontline health workers in our heads and in our hearts. Many of us came into this work out of a deep commitment to health equity, a belief that where you are born should not determine whether you survive. In the halls and cacophony of this week, may we remember our why. We are witness today to the hard and tireless work of community and frontline health workers. We're inspired by the witness of our colleagues, Roger, Treveni, Edith, and Vivian. I pray we all leave here with a dose of urgency and a prescription for perseverance. Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, our panelists. Thank you. Thank you. Good evening, everybody, once again, and welcome back from New York to Abuja. Thank you. We appreciate your patience and all that. If you haven't had something to eat, after the group picture, you will find something to eat if you have not had something to drink and to eat and to drink. On behalf of the country director for Jhpiego Nigeria, we want to say a big thank you to everyone that has participated and come to this event. We'll be inviting you in subsequent ones and would appreciate if you do come. Thank you. Please be patient for a minute so that we can take pictures with the panelists, and then you can also take a group picture together. Thank you. Yeah, so then you will come down and the panelists alone. Yeah, oh, that's it. Let's go. Then the panelists alone. No, the panelists, yeah. Come, you're going to come down, come down. No, stay there, stay there. You stay there. Okay, okay, you come down. Okay. Okay. Okay, you need to go back again. Please do not go. We'd like to take pictures with you so that it's on record that you came. Yeah, they went to do your Okay, thank you very much. Dr. Ade, please, with the Jhpiego country director. Okay, you're not done yet. Oh, yeah, sorry. Yes. So let's come and take the group photograph now. Thank you. Dr. Jhpiego, please. Yes. The Ministry of Health. I want to say a big thank you to all the Ministry of Health people that came. I am so happy you came. I owe you one. Yes, I owe you one. Yes.